A very good morning to my respected teachers, my seniors, my colleagues, and my juniors. And presentation of my topic is Central Visual Field Techniques for Evaluation. And before going to this topic, I would like to give the thanks to my moderators, Dr. Gauri Shankar Shrestha sir, Dr. Sanjeev Kumar Mishra sir, and Mr. Suraj Chetri sir, and me myself, Sagar Pandey. In this topic, we will discuss about the introduction of the visual field, central and the peripheral visual field, and under the central visual field examination, we will discuss about the automated perimetry, tangent screen, Berkeley central field test, Amsler grid, and finally summary. Visual field is the portion of visual space in which objects are visible during steady fixation of gaze in one direction, and this figure shows the tracheal island, is also called as the hill of vision, is also called as the island of vision surrounded by sea of darkness. It is 3D graph of visual sensitivity having the fovea here and blind spot on the temporal side where the DLS stands for the differential luminance sensitivity. Anatomically, blind spot lies 15 degree on nasal side of fovea but temporally to the visual field. Talking on the retina versus the visual field, that is visual field coordinates are opposite of retinal coordinates in which light entering from superior field is detected by the inferior retina and vice versa for another one, and light entering from the temporal field is detected by nasal retina and vice versa for the temporal retina one. Extent of normal visual field, which is 65 to 70 degrees superiorly, 60 to 65 degree nasally, 70 to 75 degree inferiorly, 90 to 110 degree temporally. Central visual field. Central visual field includes an area from fixation point to a circle of 10 degree, and fovea is at 0 degree, off center is 1 or less than, parafoveal is 3 degree not less than 1 degree, and paramacular is 5 degree not less than 3 degree, and macular is the central 10 degrees. Visual field can be classified into the central and peripheral, in which central visual field can be assessed by visual acuity up to 5 minutes of arc, Amsler grid up to 20 degree, but here we are only going to discuss about the central 10 degree, Berkeley central visual field up to 10 degree, and automated up to 10 degree only, Goldman central 10 degree only, and in the peripheral visual field test, there is a confrontation, perimetry, arc perimetry, Goldman, and the tangent screen measures up to the 30 degree, but we are going to discuss in the central also up to 10 degree of visual field. Term describing the central visual field defects. Central visual field defects, which occurs when there is defect in the fixation only, and the sequocentral, that is from fixation temporal to the blind spot, and the paracentral is region next to but not including the fixation. Importance of central visual field testing. It is important to find out the extent of visual field to diagnose and detect the disease as well as the extent of damage caused in visual field by disease, that is macular degeneration, diabetic retinopathy, and optic neuritis, and evaluating the symptoms like the visual distortion, that is called as the metamorphopsia, that is called as the visual defect that causes the linear object wavy or curvy or rounded due to problem in the retina, and metamorphopsia will be discussed later in the topic Amsler grid also, or the scotoma, and to find out the progression of disease in case of the advanced glaucoma. Ocular pathology affecting central visual field. ocular pathology, a visual acuity, clinical features, visual field defects, and there is prognosis. And in case of the age-related macular degeneration, there is the reduced visual acuity with a metamorphopsia, drusen, epiretinal membrane, and subchoroidal hemorrhage. And there is the central scotoma with the reduced foveal threshold, visual field defect, and prognosis is progressive. And in case of the diabetic maculopathy, there is vision reduced slightly to the hand movement, and there may be the edema or distortion of the visual images, and there may be presence of hard exudates. And relative scotoma with the reduced sensitivity in the macular area can be seen, and the treatment may stabilize the vision. And in optic neuritis, there may be acute to the severe vision loss, and symptoms like the pain on eye movement, color desaturation, and exudates on the macula can be seen. And the central or the sequocentral scotoma visual field defect can be seen with a variable prognosis. In case of the Stargardt disease, there is the reduced vision with the macular dystrophy, distortion, reduced color vision, having the central scotoma visual field defects with a progressive or inheritable prognosis. And in a CSR, CSR stands for the central serous choroid retinopathy with having the reduced visual acuity, that is slight to moderate one, with the edema and visual distortion and micropsia as the clinical features, having the relative scotoma visual field defect with a self-limiting prognosis. And ischemic optic neuropathy ION with a severe visual acuity loss from moderate one, and it is just similar to the optic neuritis, and there is loss of visual field with poor prognosis. And in the macular hole, there is the vision loss with the wavy or the distorted clinical features, and having the central scotoma with a guarded prognosis. And in case of the central retinal artery occlusion, CRAO, there is the vision loss with the distorted vision, having the central and peripheral visual field defect with guarded prognosis. Central visual field can be assessed by automated perimetry, that is Humphery or Octopus 1, and Jjerrum'sTangent Screen, Berkeley Central Field Test, and Amsler Grid. Number one is automated perimetry for central visual field testing. It is a computer-assisted static examination of visual field in which test target is placed at a pre-selected field position and is gradually raised until the patient detects it. Output is in the form of grayscale with a darkness of the shading corresponding to decreased sensitivity in the field. Advantages of the automated perimetry are it removes the subjectivity of the perimetrist, improve the uniformity and the reproducibility. Computer provide the facility of random presentation of targets, estimation of patient reliability, and statistical evaluation of data, faster, more accurate, and informative. Programs in Humphrey for central field examination, and in this, we have the two programs, that is Central Macula and Central 10-2. First of all, we are going to discuss about the Central Macula. It is localized test having the 16 location. Okay, here having the what 16 locations with the 5-degree central 5-degree, having the 2-degree spacing in between them, and each location is tested 3 times to provide the better estimates and test central macula portion. And in the central 10-2 program, it provides a high resolution test of central 10-degree with a tight 2-degree grid and 1-degree grid from this meridian, and having the total 68 locations, and examine the central 10-degree of visual field. and useful in carefully determining central or paracentral scotomas. Testing strategies in Humphery for central field examination. Staircase method is used, and staircase method is the combination of ascending limit and the descending limit. In ascending limit, stimulus is presented increasingly level until seen by the patient, and in descending level, stimulus is initially presented clearly visible and reduced until no longer can be seen by the patient. And in staircase method, there is a full threshold testing, and the CETA PSC and the CETA is based. And in full threshold testing pattern, that is the staircase consists of the 4 decibel decrement in the light intensity until the patient failed to respond first reversal, then 2-degree increment until the patient sees the light again, that is second reversal. This is the final level is the sensitivity recorded, and it is the full threshold staircase strategy. Second one is CETA PSC, which uses the 3 decibel step size, which terminates on crossing its threshold. Threshold is recorded as the last seen stimulus. Drawn back is the short-term fluctuation, more an increased threshold error, thus reducing the reproducibility. Third one is SITA, which stands for Swedish Interactive Threshold Algorithm, and SITA compares the threshold of a patient with recorded normal and abnormal values and provide probability plotting, and SITA adapts the stimulus presentation speed to the reaction times of the patient, which in most cases reduces test time, and available in two forms, that is the SITA standard and SITA fast, and SITA fast more faster with less accuracy than that of the SITA standard, and the difference between the two is chosen level of accuracy for the threshold estimation. Comparison of visual field defect in central macula and central 10-2. In the diseases like ARMD, that is the age-related macular degeneration, under the program of the central macula, there is central scotoma can be seen, but in the program central 10-2, central scotoma with the reduced central sensitivity can be seen. In case of the diabetic retinopathy, microaneurysm may lead to the localized scotoma, can be seen in case of the central macula program, but localized or the diffuse reduction in sensitivity with the paracentral scotomas can be seen under the program of central 10-2. In the macular hole, central scotoma with the decreased sensitivity can be seen in the central macula, but in the central 10-2, central scotoma, possibly with the ring of increased sensitivity around it, can be seen. In the glaucoma, that is in the advanced stage, that is late stage, can affect the central vision, and which can be assisted by the central macula. And in the under the program central 10-2, early or the late paracentral scotomas or nasal step or arcuate defects can be seen. In optic neuritis, central scotoma can be seen in the central macula program, but in the central 10-2 program, central scotoma with a reduced sensitivity in the central area can be seen. In the hydroxycurarine toxicity, parafoveal ring scotoma can be seen, but in the central 10-2, there is the bilateral central or paracentral scotomas with the loss of sensitivity can be seen. In the Stargardt disease, there is the central scotoma with the decreased sensitivity in the juveniles in the under the program of central macula, but in the central 10-2, central scotoma with the irregularities in the central field can be seen. And another one is the examination program in the Octopus. It is no more in use nowadays and replaced by the Humphery perimetry, but considered to be the first automated perimetry. And it has the different kind of models, and among them it is the Octopus 300, and another model is the Octopus 700, and so on. It has the two program that is called is the Macula YUM1, YUM2, and the program G1, G2. Here we are only going to discuss about the Macula YUM1, YUM2, which covers only the central visual field, and it is used to assist the central and paracentral visual defect in neurological and the macular problems. And under the program YUM1, there are 56 test locations in an equidistance grid pattern with a spacing of 2 degree. Under the program YUM2, there is 45 test locations in central 4-degree area with 0.7 degree spacing. Another one is the tangent screen, also called the Bjerrum's screen, which measures up to the central 10-degree visual field. And simplest form of perimetry uses a white tangent screen of circular stitching every 5 degree on the dark background, designed to evaluate the central 30 degree at 1 meter, but can be used to test visual field at central 10 degree also. Bjerrum's screen can be used in case of the diabetic retinopathy also, glaucoma also, malingers also, and a lesion affecting the visual pathways also. In order to calculate the angular position in the Bjerrum's-Tangent screen, that is the distance from the fixation point is divided by fixation distance to obtain the tangent of angle, and meridian of the tangent screen are usually laid out with a black stitching like a dial of clock, and test not only the light sensitivity of retina but also depends on motion detection. There are the different kind of stimuli used in the Bjerrum's-Tangent screen. One number is the target size stimuli. Another one is the color stimuli. And first of all, we are going to discuss about the target stimuli. There are the different target stimuli of 20 mm, 10 mm, 8 mm, 4 mm, and the 2 mm. And the 10 mm target stimuli can be used to the patient having the vision 624, but the 2 mm target stimuli can be used to the patient having the 6/6 vision. And color stimuli, there are the three types of the color stimuli present in the Bjerrum's-Tangent screen, that is the red one, blue one, and the green one. In the red one can be used for the assessment of the neurological problems in the different kind of patient, and the blue one can be used for the diabetic retinopathy and the glaucoma one, and green one can be used for the patient having the macular degenerations. And in Bjerrum's-Tangent screen, 1 mm wide target is moved from the central fixation point along horizontal meridian to right, and central field using target of 1 mm to 1000 wide target for the plotting of the central and paracentral scotomas, and the paracentral scotomas can be detected by presenting the target at roughly clock interval around the 15-degree radius from fixation. The blind spots should using 5 mm by 1000 wide target stimuli. Another one is the Berkeley central field test, having the simple PowerPoint presentation of 50-point scoring system. Central 10 degree of visual fields can be assessed by this, and having the dark line on the white background can be used, and viewing distance is twice the distance between the long vertical red line seen at the edge of each sides. Test target substance approximately 30 minutes of arc, equivalent to the 10 mm to 1000 white stimuli or Goldman's third, having the 20 target position superiorly and 30 target inferiorly. 5 points are tested along 10 different hemi-meridian, and the 4 hemi-meridians in the superior field and 6 hemi-meridian in the inferior field. Through the Berkeley central field test, metamorphopsia and the phenomena of filling in and scotoma cannot be detected. That is, phenomena of filling in means an empty region of visual space appears to be filled with the colors, brightness, or the texture of surrounding. However, it detects the loss of sensitivity and the presence of maculopathy. This table was taken from Nepalese Journal of Ophthalmology, which was published by Sanjeev Kumar Mishra, Gauri Shankar Shrestha, and Hiral Korari on the research paper, and showing the sensitivity and the specificity of the Amsler Grid and Berkeley central field test, and the conclusion of this research paper was the Berkeley central field test was as good as the Amsler Grid test at detecting the presence of the maculopathy. Another one is the Amsler Grid, which helps for the assessment of the central visual field and which was introduced by the Dr. Mark Amsler in 1920, in which the manual comprises of the 7 chart and having the area of 100 centimeter square, and it is in the square shape. And when it is held 33 centimeter from the eye, it helps for the assessment of central 20-degree visual field, and it is important in testing the macular function. Amsler grid can be used in the patient when there is no improvement of the vision even with the pinhole, and in the suspected macular diseases and abnormal color vision and suspicious appearances of the macular area. And there are the 7 types of the Amsler chart, that is the chart 1, chart 2, chart 3, chart 4, chart 5, 6, and chart 7. And talking about the chart 1, it is the most familiar and widely used, and each grid corresponds to 1 degree of visual field and widely used in identifying the distortion and the scotoma. And the chart 2 is similar to the chart 1, having the diagonal line which intersect at the center of the grid to form in the X-like pattern. And this diagonal helps us to know the limit of the scotoma. And talking about the chart 3 is also similar to the chart 1 but having the red square on the black background, and which helps to stimulate the long wavelength foveal cones, and it is useful in the case of the central or secocentral scotoma, toxic maculopathy, which is caused by quinone toxicity, and the color scotomas and the color desaturation of the optic neuropathies. And talking about the chart 4, it is the chart 4. In the chart 4, there are the many small white dots randomly scattered on the black background, and it helps to differentiate between the scotoma and the metamorphopsia. And in the chart 5, there is the 20 evenly spaced horizontal line on the black background, and it helps to detect the metamorphopsia along with specific meridian, and it can be rotated in any meridian. And in the chart 6, parallel lines are closer to each other 0.5 degree above and below the fixation point. And chart 6 helps in the metamorphopsia detection along the reading level. In the chart 5, and this chart breaks the horizontally oriented 6 degree cross 8 degree central area corresponding anatomically to the normal macula into 0.5 degree squares, and it is for the subtle macular diseases. Comparison of the Amsler chart, and through the chart 1 we can detect the distortion and the scotoma, and with the help of chart 2 we can detect the limit of scotoma, and with the help of chart 3 we can detect the central or secocentral scotoma, toxic maculopathy caused by the quinone and its derivative, and the color scotomas and the color desaturation of the optic neuropathies. And with the help of chart 4, we can differentiate between the scotoma and the metamorphopsia. And with the help of chart 5, we can detect the metamorphopsia along specific meridian. And with the help of chart 6, we can detect metamorphopsia along the reading level. And with the help of chart 7, we can detect the subtle macular diseases. Finally, we have reached to the topic metamorphopsia, and metamorphopsia means the visual defect that causes linear object, wavy or curvy or rounded one. It occurs due to the when there is the problem in the retinal layers, and metamorphopsia is further classified into the macropsia and the micropsia. In macropsia, macropsia, lines seen as enlarged and the space occupying the pathology that may be the tumor, which force the cone closer, causing the grid to be seen distorted, and the retinal image will fall on more cones than that of the normal one. This is a figure showing about the macropsia, in which lines are seen as larger. In micropsia, lines are seen as smaller, and the patient with the macular edema or any other pathology that forces the cone apart, and the retinal image will stimulate fewer cones than that of the normal one. This is the figure of the micropsia, in which lines are seen as the smaller. There are the 5 series of the question which generally asked to the patient, and number 1 question is, can you see central white dot? In order to rule out central scotoma and relative scotoma. And number 2 question is, can you see all 4 sides of the large square and all 4 of its corner in order to rule out the arcuate field defect? And question number 3 is, are any of the small squares blurry or missing on any part of the grid in order to rule out relative or absolute or secocentral scotoma? And number 4 question is, do any of the horizontal or vertical lines appears wavy or bent in order to rule out metamorphopsia? And number 5 question is, any part of the grid is quivering, flickering, or the colored in order to rule out the skin dilating? And through the 5 series of the question, we can detect the retinal diseases such as metamorphopsia, yes, sequocentral scotoma 1, and so on. Limitation of the Amsler grid. There is a high level of the false negative reports, and the presence of the scotoma was noted in 2% of control subjects who had no symptoms of scotoma. Use of a preferred retinal locus away from the scotoma boundary, asymmetry of the attentional deployment in the peripheral retina, and the phenomena of filling in. Summary: and central visual field helps for diagnosing, early detection, and managing disease affecting macula and central vision. These are my references through which I take the all information of central visual field. And thank you.